All right, so we're going to talk about multiple sclerosis today. Briefly, before we start, these are my disclosures. The objectives of the talk. I am sharing the screen and I hope it is working. I'm not sure if it is. Okay, so what do we want to get out of this talk? We want to identify the typical MS patient. We want to outline the key features in the history and exam that are important in MS. We want to recall the 3 elements necessary to diagnose MS. We want to be able to recognize and treat an MS exacerbation. And then we want to learn how to treat some of the non-neurologic symptoms of MS. And time permitting, we will talk about some of the disease-modifying therapies of MS. So this is briefly the lecture outline we will follow. So what is multiple sclerosis? Multiple sclerosis is an autoimmune disease. Autoimmune diseases are diseases where the immune system recognizes the body as foreign and attacks it. It is an autoimmune disease of the central nervous system, the central nervous system being the brain and the spinal cord. The peripheral nervous system is the peripheral nerves, muscles, neuromuscular junction, etc. So one of the things I learned in medical school was that if you have a presentation and you show some history, it makes you look a lot smarter. So here's my slide on the history of MS. So the earliest Western case of MS was in the late 14th century. Jean-Marie Charcot, who is well recognized in many, his name is also part of another disease called Charcot-Marie Tooth disease. He first described MS in the Western literature. There is some suggestion that in the Eastern literature, this may have been described even earlier. Avicenna, also known as the Prince of Physicians, had some notes to suggest that MS may have been described earlier there. In 1841, we had the first brain pathology of MS. So who generally gets MS? Generally, it is young females. 95% of MS is diagnosed between the ages of 15 and 55. So if you find an MRI in a patient who is above the age of 55, you have to look for other conditions that can mimic MS, and we'll talk about those as well. MS affects around 0.1% of the general population, so it is fairly prevalent. Females tend to be affected twice as often as males, and this is seen in many autoimmune diseases. We know that there is a genetic component to it, HLA-DR2, which is the same in several other autoimmune diseases as well. We also know that there is an environmental prevalence. So for instance, earlier studies suggested that there was virtually no MS at the equator, but as you go away from the equator, the incidence of MS increases. So because of this unique distribution, people came up with many hypotheses. Some people suggested it could be vitamin D. There's a lot of vitamin D sun exposure at the equator, but not so much as you move away. Could it be a virus that is found more in tropical and equatorial climates, magnetic fields? Recently, there was a European vascular surgeon who suggested that MS is caused by cerebrospinal venous stenosis, and he was stenting people. Several large studies done afterwards suggested that actually this procedure increases the mortality. So progressive MS is slightly different than relapsing remitting MS. It is more degenerative as opposed to inflammatory. Generally affects more older males, more spinal cord lesions, and instead of relapses, you have just accumulation of disability. Pathophysiology of MS. Let me see if I can make this better. So what do we know about the pathophysiology of MS? We know that there is a genetic susceptibility. We know that there is also an environmental component to it. We also know that there is an abnormal immune response directed against oligodendrocytes. For instance, we know specifically we have identified certain antibodies against myelin, so myelin basic protein. One hypothesis is the hypothesis of molecular mimicry. So what does this mean? Basically, the idea is that you get infected by a virus, perhaps in your childhood. Your body takes care of the virus, but then myelin shares certain epitopes with the virus, and so later on in life, the body's immune system then attacks the myelin. But this is actually a fairly simplistic understanding of the reality. So molecular mimicry was actually used in the making of glatiramer acetate, one of the treatments we have for MS. Glatiramer acetate or Copaxone is a polypeptide which shares some epitopes with myelin, and they actually made it to cause MS, to cause an animal model of MS. But then they realized it actually improves MS. The idea was that probably just sequestering some of those bad antibodies that are directed against myelin. So the reality is that it's a little more complex than that. So everybody is born with some autoreactive T cells. These autoreactive T cells are educated in the thymus. So they go to the thymus, and then there's a clonal deletion of autoreactive T cells that happens in the thymus. So we think that there is a failure of this clonal deletion in individuals who are susceptible to MS. So this is a recorded Zoom lecture, and it's not interactive, but if this was interactive, I would ask how many of you are aware of the hygiene hypothesis? And then I would ask how many of you have been infected with an intestinal worm? So there's an idea, the hygiene hypothesis idea is that your immune system needs a pathogen to react against, usually in childhood. So early childhood exposure to bacteria, virus, fungi, animal dung helps the immune system to be exposed to pathogens and react to it. If it does not get this exposure, it then reacts instead to its own self or to the body. There is a study that if you have been infected with an intestinal worm, your risk of MS is very low. Okay, so pathology was my least favorite subject in medical school. So we spend very little time on pathology. There are two main things you need to know. In gross pathology or anatomic pathology, you need to know that MS has a predilection for these areas: periventricular, optic nerve, optic chiasm, and the spinal cord. In histopathology, paravenous infiltration of inflammatory cells. That's your keyword. So brief basic science review, you probably know this much better than I do, but neurons are insulated by myelin. Myelin is produced by oligodendrocytes in the central nervous system and Schwann cells in the peripheral nervous system. The action potential moves from one node of Ranvier to another, which causes the hastening or speeding of the action potential. MS then is an autoimmune attack on oligodendrocytes. So you get these lesions and the speed of conduction is slowed down, which gives you the clinical phenotype you see. So MS is one of several demyelinating diseases. It is the most common demyelinating disease, but there are others as well, including neuromyelitis optica, ADEM, and then these acute and subacute necrotizing hemorrhagic encephalitides. So let's talk a little bit about a few of these. So neuromyelitis optica, it was initially thought to be a variant of MS, but today we consider it a separate disorder. The lesions, there's a predilection for lesions of the optic nerve and the spinal cord. You get longitudinally extensive transverse myelitis, so very long spinal cord lesions. There have been a couple of autoantibodies identified, including the aquaporin 4 channel or the NT-MOG, a myelin oligodendrocyte protein. CSF often will show pleocytosis or more than 50 white blood cells, which is not common in MS. The prognosis is worse than MS. 5-year survival with more than one attack is only 68%. Treatment is generally, heavy immunosuppressive medications. There has recently been a new FDA-approved medication called Soliris, which was at one time the most expensive medication in the world. It's a complement-mediated mechanism by which this medication works. So these are a few MRIs of neuromyelitis optica. So you can see in the image on your left, the MRI shows a longitudinally extensive transverse myelitis. On the right, you see the optic nerve is enhancing with contrast, suggesting inflammation there as well. ADEM, this is a disorder of childhood in general. It is monophasic, meaning happens one time and does not relapse generally. Often seen after vaccines or infections. You have massive demyelination all of a sudden. People are pretty sick, fever. You treat this with high-dose steroids, and generally there is a complete recovery. This is what ADEM looks like. So lots of white matter lesions all over, but generally good recovery with steroids. So most of you have seen this kind of diagram in some of your textbooks somewhere. And this is kind of how we think of MS, although this is changing a little bit more recently. So relapsing remitting MS, this is the most common subtype of MS. Basically, the idea is you get a relapse and then you go back to normal. Another relapse and back to normal. The reality is that there is a little bit of disability accumulation in between these relapses. Secondary progressive MS is when relapsing remitting MS becomes more progressive in nature, and instead of having discrete relapses, you have only increasing disability. Primary progressive MS is basically relentless progression from the onset with no discrete relapses. And then you kind of have some hybrid forms of MS. Now, this is a two-dimensional view of MS. There is a three-dimensional model of MS that was proposed by Dr. Krieger, and it's a very nice way to think about MS. So if you think of this water tank, which has a slanted bottom, this is the water level is the clinical threshold. These are lesions. If you have a lesion that crosses the clinical threshold, it becomes phenotypically apparent. You have a clinical relapse. You can have silent lesions, in which case you don't really have any clinical symptom. And these are most commonly seen in the cerebral hemispheres. So for instance, a lesion in the frontal lobe will be less apparent clinically than a lesion in areas where there's very little real estate, such as the spinal cord or the optic nerve. So we're going to watch a quick video. Now, over time, you will notice the water level is decreasing, which is supposed to indicate the progressive form of MS, which is more degenerative. Let's see if this will play on the same screen. I think it should. So you can see these are silent lesions. They don't cross the clinical threshold. And if you keep an eye on the water level, it's decreasing very slightly. That's a clinically apparent lesion, but then you have relapses and doesn't leave any residual. So over time, you accumulate more lesions. At the same time, you're having some progression, and previous lesions are becoming more apparent as well. And then over time, you have less relapses, but more progression. So you try to fix out of that. Close this. and go back to our slide. So how do we diagnose MS? So you might have heard of the McDonald's criteria with its multiple reiterations and revisions. So if you want to pass your neurology clerkship, you have to memorize this. Not really. So we're going to make diagnosing MS made ridiculously simple. You need three things to diagnose MS. One, you need a clinical history suggestive of MS. So what is this? This is basically a history of transient focal neurologic dysfunction that comes and goes. Then you need evidence of lesion dissemination in space and evidence of lesion dissemination in time, meaning you need more than one lesion and you need lesions at different times. However, with the most recent reiteration of the McDonald's criteria, oligoclonal bands may actually replace, we can have a single lesion with oligoclonal bands and you can diagnose MS. So what are the signs and symptoms of MS? Well, it's very variable depending on where the lesions are, but despite the lesions, there are certain symptoms and signs that are very common in all MS. Fatigue is the most common complaint in MS. A lot of other things such as bladder and bowel dysfunction, sexual dysfunction, tremors, spasticity, ataxia. The symptoms of MS are subacute. They don't come on acutely. If you have a focal neurologic deficit that comes on acutely, all of a sudden, you have to think stroke and not MS. They tend to resolve subacutely as well. It is actually pretty rare to have aphasia, frank aphasia, which is more common in strokes or seizures. And hemiparesis, inability to move the arm completely, is also less common in MS than in stroke. This was a study looking at the most common presenting symptoms of MS. And if you notice here, the most common one is limb sensory loss. The reason I highlighted this study is this is a disease of young females, and limb sensory loss in young females will make many neurologists think of conversion disorder or psychogenic etiology, but it is important to rule out MS. So what do we expect to see in the physical exam in patients with MS? Again, very variable depending on where the lesions are and how long this patient has had MS. So later on in MS, it is common to find upper motor neuron symptoms, which includes spasticity, hyperreflexia, Binsky sign. Internuclear ophthalmoplegia is very common in MS, and bilateral internuclear ophthalmoplegia is almost pathognomonic for MS. So we'll show you a video of this. Relative afferent pupillary defect, also very common in MS from optic neuritis, and we'll show you a video of this as well. This is mainly for your step 1 or step 2 or step 3. They commonly put this triad on in MS patients. So what is the differential diagnosis of MS? Well, several things, ranging from vascular, infectious, neoplasms, especially CNS lymphomas or metastases. There is a huge overlap between connective tissue disorders and inflammatory disorders. Sjogren's, there's supposedly a neuro-Sjogren's, CNS vasculitis. Crohn's disease and the use of anti-TNF medications has been associated with MS-like lesions in the CNS. Certain infectious diseases, tropical spastic paraparesis caused by which virus? If you said HTLV, you are correct. Several genetic or metabolic leukodystrophies, including Alexander's disease, Canavan's disease, etc., can all look like MS. So basically, although you have a huge differential diagnosis and several things can mimic MS, oftentimes it looks like MS, it acts like MS, and it is MS, and we don't need to order extensive testing in order to disprove all the other diagnoses. So clinically isolated syndrome. This is the first attack of MS. It could become MS or it could remain as a clinically isolated syndrome. It could be several things, but commonly optic neuritis or transverse myelitis. There is a lot of evidence to suggest that if there is oligoclonal bands with clinically isolated syndrome, then treating with MS medications actually improves outcomes. So when somebody presents with clinically isolated syndrome, it is important to do an extensive workup to rule out other causes and treat the MS if it is MS. So we'll take a little bit of a breather and watch some videos of common MS symptoms. So this is intention tremor. It is a cerebellar tremor. If you notice, the tremor gets worse as the patient's hand approaches the target. This is severe tremor. So it's worse as they approach the target, which is very common with cerebellar tremors. This is nystagmus. A couple beats of nystagmus is normal, even in normal people, but more than that is abnormal. You always describe the nystagmus based on the direction of the fast phase. So in this case, this was left beating nystagmus, I think. You can have vertical nystagmus, horizontal nystagmus. Okay, so optic neuritis. This is a common presenting symptom of MS. It's a demyelination of the optic nerves, and remember the optic nerves are actually a CNS white matter tract. You get painful loss of vision, which then recovers with steroids. An MRI will show you enhancement of the optic nerve, which we saw in neurological exam. You will see a relative afferent pupillary defect and optic disc edema. Important to do a spinal tap and to rule out other causes, such as infections, vitamin deficiencies, etc. So this is a picture of a normal fundus. This is your optic disc with very sharp borders. In this case, focus on this and not on this, which is a completely separate thing, retinal star, neuroretinitis. But this is what we're looking at. And you see the borders are not sharp at all as compared to the previous one. So there's optic disc edema. This is a video of relative afferent pupillary defect. And as we watch the video, you will try to figure out which eye is abnormal. So you can play the video back again, and I can do that too. So basically, there are a couple things going on here. If you notice, the right eye does not constrict when light is placed on it. The left eye does initially. But then when they do the swinging flashlight test, the left eye actually dilates when light is shined on it. So why is that? So basically, it is reacting actually. So I apologize, I might have mistaken the left and the right, but the eye on the left is abnormal, and the reason it is actually dilating is because it is reacting to the darkness on the other side. So this is an internuclear ophthalmoplegia. Where is the lesion in an internuclear ophthalmoplegia? You can pause the video here and think about it. If you said NLF, you are correct. And bilateral INO is almost pathognomonic for MS. So we'll look at the video.
Look to your left. Look to your right.
So you notice when you look to the left as well as looking to the right, there is nystagmus,
Look to your left.
and the eye does not abduct completely. I'm going to try to explain it using a diagram if this video works. Background, but okay. So basically, let me see, it might take too long to get rid of the background, but basically you have your, let me see if I can use a whiteboard. Okay, in any case, so the MLF is a white matter tract that connects cranial nerve 3 to cranial nerve 6, and it is a one-way road, or one-way fiber tract that goes from down to up only. So it starts with cranial nerve 6 and ends with cranial nerve 3 on the other side. So it crosses, it's a cross track like this. You have your cranial nerve 3 there, cranial nerve 3 there on that side, and below here, where my thumb is, you can have your cranial nerve 6. So if you activate cranial nerve 6 on your left side, you will move your left eye to the left, and you need to simultaneously activate cranial nerve 3 on this side of the right eye so that they move conjugately. But you have a lesion, and so 6 gets activated but 3 does not. So you will the right eye will not AD duct, and then you'll have double vision, and then the left eye will come back with nystagmus. If it is possible, I will try to send a picture of this later on. Okay, so transosmyelitis, another common presenting symptom of MS, basically demyelination of the spinal cord, can present with these symptoms: sensory loss, heaviness in the extremities, bladder issues, weakness. Very important to do a spinal tap, rule out other causes. So this is transosmyelitis. You can see an MRI where there's contrast enhancing of the cord. Okay, so how do we diagnose MS? The most common tests are the MRI, the LP, and the evoked potentials. We tend not to use evoked potentials that much. MRI is the most important. So lumbar puncture. We draw CSF, we send for protein, cell count, differential, ground stain cultures, myelin basic protein. Basically, what are we looking for? There might be a slightly elevated protein, but not necessarily. White blood cells more than 50 should prompt you to look for an alternative diagnosis. Now, for all practical purposes, for your step 1, step 2, oligochromal bands is MS. But you should realize that this is not entirely true. You can see oligochromal bands in several other conditions, and not having oligochromal bands also does not rule out MS. And that's just the same thing, basically. I'm up to date. Okay, evoked potentials, you present a visual stimulus, record the time it takes to reach the optic cortex, occipital lobes, and when there is a lesion of the optic nerves or tracts, it will take longer, so that will have a latency increased and velocity decreased. Imaging. So MRI is the test of choice. Many times a CT scan is ordered for these patients when they present to the patient with known MS presents to the emergency room. They get a CT scan, basically subjecting them to unnecessary radiation. CT scan is good for trauma, skull fractures, bone fractures, or bleeds. Not very good in MS. So in an MRI, your T1 is kind of like your CT. It's good for anatomy, but not much else. Your T2, CSF with an attitude. T2, CSF with an attitude. CSF is bright on your T2. Flare, subtract the attitude. So flare is very important in MS, and we'll see why later. So on T1, you will see old lesions, and they will appear hypo-intense, as black holes. So in MRI, we talk about intensities. In CTs, we talk about densities. A T1 post-contrast is very important for relapses. So if there is a relapse, you want to do an MRI with contrast, and you will see contrast-enhancing lesions. Now, it's important to realize that the FDA currently has an advisory on gadolinium, and the advisory is that only use it if it's absolutely necessary, because it accumulates in the basal ganglia, amongst other places such as the bones. So we'll look at a few MRI images. This is a flare, T2 flare And you can kind of see these periventricular lesions as well as juxtacortical lesions. The periventricular lesions are your Dawson's fingers, which we will see much better in the next slide. Here it is difficult to see, but you have a lesion in the higher cervical cord there as well. This is your sagittal flare, very important sequence in MS. And you can see these Dawson's fingers. They kind of look like fingers on the corpus callosum. In an MS exacerbation, you want to do a T1 post. So if you look at your T1, you have a black hole which shows an old lesion. But this old lesion is acting up, and you see it's enhancing with contrast with this ring of contrast enhancement. Now, if you look at this T2 image and look at it carefully, you won't be able to see any lesions. Everything looks good on this image, and it's easy to miss a lesion. And this is why the flare sequence is very important. You subtract the attitude from the T2, and there you have a periventricular lesion hiding near the CSF there. Sometimes MS can look like this. This is tumor-factive MS, and it's called tumor-factive because it looks like a tumor. In these cases, you usually need a biopsy in order to determine what this is before you treat it. So in MS flare or MS exacerbation, this is when a patient with known MS either develops a new symptom or an old symptom starts acting up again, gets the same old symptoms again. Now, what do? You make sure you rule out pseudo-exacerbation. So infections such as UTI or pneumonia can cause old symptoms to come back. These are pseudo-exacerbations. Once you rule that out, the ideal thing is to do an MRI with and without contrast, and then treat with IV steroids. There may be a role for other agents such as Acthar, oral steroids, plasma exchange, but we won't go into that too much. Treat them with IV steroids. Okay, so disease-modifying therapies of MS. These are the medications we give on a day-to-day basis for our MS patients. Now, it is important to discuss with your patients these principles of disease-modifying therapy. Number one, these medications do not cure MS. They also do not necessarily make the patient feel better, nor do they alleviate the symptoms. All they do is decrease the relapse rate, and some of them may prevent disability. It's important to convey this to your patients because some patients will take the medication and say, I'm not feeling any better, and stop the medication. It's also important to address other risks, vitamin D, which we'll talk about in a little bit, smoking, obesity, diet, heat, etc. So when I was in residency, we had only injection treatments, 3 or 4 injection treatments for MS. This was the platform therapies. The first oral medication for MS came about when I was in my residency, which was fingolimod. And now we have a whole slew of treatments for MS. So in order to try to understand these and keep them straight, I've divided them into basically 3 categories. There's a little bit of overlap. The platform therapies are all injection therapies, and we'll talk about them briefly. The moderate agents are your oral agents, and then you have the stronger agents, which are IV. The efficacy increases as you go from left to right, but the adverse effects or risks also increase in a similar way. Cladribine is an oral drug, but I put it with the IV infusion drugs, and we can talk about that in a little bit. So, the platform therapies, these are also known as your ABCs, Avonex, Betaseron, Copaxone. Rebif is also there. So all of these drugs, with the exception of Copaxone, have side effects of basically flu-like illness. So people don't feel good with these medications. Copaxone has a different kind of side effect, and that is chest pain in some people. Copaxone is also felt to be not as efficacious as the others, although you can't really say that because there have not really been comparison trials between head-to-head trials between these drugs. Your second generation disease-modifying therapies are your oral therapies. Fingolimod or Gilenya, first oral therapy, causes bradycardia, so it's important to bring these patients in for us First dose observation, 6 hours. If they have a risk factor for heart disease, heart rhythm disorders, then we do not give this medication. Can reactivate varicella zoster. Both tecfidera and fingolimod have a risk factor for PML. They increase the risk of PML, which is a fatal brain infection. Dimethyl fumarate or tecfidera, another oral drug, also causes PML. The major side effects with this one are GI side effects and flushing, which are pretty severe, and so it's not as well tolerated. Teriflunomide or Aubagio is not felt to be as immunosuppressive as the other two. It can reactivate TB. It is teratogenic in both the male and the female, so it's important to counsel your patients on this, and it's not a good drug for young patients. It can also cause alopecia or hair loss. Okay, then your IV drugs, your natalizumab or Tysabri. This is a very potent drug that was on the market, then taken off because of a high risk of PML and is back on the market. In general, if the JCV antibody status is negative, the first 2 years, people do really well on this drug and the risk of PML is minimal, but it's important to screen every 6 months with the JCV antibody test. Lemtrada or lemtuzumab, this is also known as Campat, used to be a cancer drug. It basically wipes out the immune system and resets it. And because of that, you have a huge incidence of autoimmune disorders after, usually after a couple of years, maximum. So this is approved for 2 doses a year apart. Also recently, there's been cases of stroke and vasculitis associated with this drug. Ocrelizumab or Ocrevus. This is basically rituximab that is humanized, given every 6 months, and it's also approved for primary progressive MS. Can increase the risk of breast cancer and can reactivate hepatitis and also PML. Some of the other treatments, dalfampyridine or Ampyra, is known as the walking drug in MS, improves walking speed, not to be given to patients with kidney disease or seizures. There are several other newer drugs which we'll talk about briefly. Siponimod is basically a cousin of fingolimod, made by the same company, a little more specific. Approved for secondary progressive MS, although they used the criteria used for secondary progressive MS was a little concerning. Also, age criteria, from what I remember, was below 65, and that's kind of when we start seeing secondary progressive MS. So, not necessarily truly effective for secondary progressive MS. Cladribine is an old drug. Initially, study was done in 2010, but there was no FDA approval because of the risks, adverse effects with this medication, and it is now on the market. Also used to be treated as PMS, but again, the studies were based on an EDSS score to determine what is secondary progressive MS, which is problematic. Mitoxantrone is hardly used anymore. It's off the market due to acute leukemia and cardiotoxicity. Daclizumab recently taken off the market due to these conditions. Okay, so let's talk a little bit about some of the non-neurological signs and symptoms of MS and how we can treat them. Fatigue, the most common symptom in MS. It's important to rule out other causes, sleep apnea, hypothyroidism. Once you rule those out and treat them, you can use medications such as modafinil or sometimes stimulants as well. Vitamin D and MS, very important. Lots of research suggesting higher levels of vitamin D are protective. So we shoot for a level of 50 to 100. Cannabis and MS, hot topic today. Many people are going to ask you about this. So basically, what I tell my patients is what we do know is that cannabis worsens cognition in MS. Clear studies showing this. So if they have cognitive problems, it is not recommended. These are a bunch of studies with cannabis on spasticity and pain. Most of these have been negative studies with a couple of positive studies, but a meta-analysis did not find any statistical significance. Supportive treatment, I won't read through all of this, but basically you can go through the slide. We talked about some of this already. Sexual dysfunction is very common in MS, and it's important to ask because this is something that patients will not necessarily bring up, and clinicians may also not bring up. Spasticity is very common, and we treat it with oral drugs such as baclofen or tizanidine, or injections such as Botox. Excuse me. Okay, so prognosis in MS. The MS prognosis today is much better than what it was 15 to 20 years ago due to the several disease-modifying therapies we now have. We know from studies that there are certain factors that portend to a more good prognosis, and there are certain factors that suggest a more severe course of disease. So if you're female, you have a relapsing remitting subtype, you have optic neuritis at onset, or you have infrequent exacerbations, these are all good prognostic factors. On the other hand, if you have spinal lesions, African American or Hispanic, or you're male, you tend to have a more severe form of MS. And the life expectancy is just slightly lower than the general population, and the major issue is not mortality, it's morbidity. So that brings us to the end of the formal part of this presentation. If there are any questions, I guess you could always email me. There is a second part which is a little more in-depth. What I'll do is I'll just go through the slides really quickly and just have you kind of read them. And this is just a more detailed view of the medications. Excellent. That concludes our lecture. I hope it recorded well, and I hope all of you are staying safe during this COVID pandemic. And I believe I will exit now.